Hey everyone, welcome back to The Explainer. Today, we're running a high-octane boot camp on bite wound infections. We've completely designed this to hardwire critical pathogen associations straight into your brain for your medical board exams. We're going to take the massive amount of data surrounding animal and human bites, and we'll distill it right down to the absolute highest yield concepts. Here is our game plan for today. We're going to start with the overall bite landscape, face off the big three, dive into some exotic trivia goldmines, review rapid-fire universal treatments, and then we'll end by exposing the most common high-yield exam traps. Let's get right to it. Section 1, the bite landscape. Setting the stakes. Okay, so when a patient walks into the emergency department with a bite, you really need to realize you're looking at a high-pressure inoculation of pathogenic flora. Cat bites, specifically, have an absolutely astonishing infection rate of over 50%. That is far higher than dog bites, which sit around, 15 to 20%. Why is that? Well, instead of a crushing injury, cats use their really sharp, narrow canine teeth to deliver a deep puncture wound. It literally injects bacteria directly into bone and joint spaces, especially on the hand. And because of that, your patient's risk for septic arthritis and osteomyelitis is incredibly high. Moving right along to Section 2, the big three. That's cats, dogs, and humans. So these are the most highly testable scenarios you're going to see on the wards and on your exams. Notice how different the clinical presentations are. Dogs usually cause lacerations and crush injuries, while cats, like we just said, cause those narrow, deep punctures with a massive infection rate. But wait, we need to look really closely at human bites. You have to distinguish between a simple occlusional bite, which is just a standard bite mark with a 10 to 15% infection rate, and the clenched fist injury. This is your classic fight bite, where a fist strikes an opponent's teeth. The infection rate jumps over 25% here, because the teeth easily penetrate the knuckle and directly inoculate the extensor tendon sheath, joint space, and the bone itself. All right, you know the mechanics, now you've got to know the bugs. When you see a rapid onset infection, and I'm talking severe inflammation, purulent discharge, and lymphadenitis developing literally just hours after a cat or dog bite, you must immediately think of Pasteurella multisida. It's the predominant pathogen in the majority of cat bite infections. The absolute buzzword here is rapid onset. If the clinical stem says the bite happened, say, 4 hours ago and the hand is already intensely swollen and red, Pasteurella is your answer. Next up is a classic exam pattern that you absolutely cannot miss: Capnocytophaga canamorsis. This little organism lives in dog and cat saliva, and it's notorious for being incredibly difficult to culture, sometimes taking up to 14 days. But the clinical picture is super stark. If a patient gets a dog bite, or honestly even just a lick on an open wound, and they happen to be asplenic, cirrhotic, or immunosuppressed, think capnocytophaga. You've got to prepare for fulminant sepsis, disseminated intravascular coagulation, and renal failure. Now, for human bite scenarios, specifically those clenched fist injuries we talked about a minute ago, Eikenella corrodens is the critical buzzword pathogen you need to lock in. It's just a normal part of human oral flora, but once it gets punched into the deep spaces of the hand, it wreaks total havoc. It's often accompanied by other nasty things like viridin streptococci and beta-lactamase-producing anaerobes. And that, by the way, is exactly why these injuries always require urgent hand surgical evaluation. Let's dive into Section 3, exotic and rare bites. These are pure trivia goldmines. Board examiners absolutely love to use niche scenarios to separate the good test takers from the great ones. First up is rat bite fever, mostly caused in the US by Streptobacillus monoiformis. The key diagnostic clue here is the timeline. The initial wound actually heals completely. Crazy, right? This is what distinguishes it from a typical direct wound infection. Then, after a 3 to 10-day incubation period, the systemic symptoms hit: fever, chills, and severe migratory arthralgias. Finally, the patient develops a classic maculopapular rash heavily involving the palms and soles. So if you see that exact sequence, bite, healing, fever, palm and sole rash, boom, it's rat bite fever. Examiners also really love aquatic environments. If a clinical stem mentions water, you need to categorize it immediately. If the bite happens in freshwater, say from an alligator or a piranha, your pathogen is Aeromonas hydrophila, which, by the way, is notably resistant to ampicillin. If it's a saltwater injury from a shark or moray eel, think marine Vibrio species, which can cause rapidly necrotizing wound infections. And if the stem mentions an Arctic environment with a seal or walrus bite, well, that gives you seal finger. That's a chronic infection caused by Mycoplasma species, and it specifically requires doxycycline to treat. Section 4, Rapid Fire Treatments. Time for some universal protocols. Okay, let's transition from identifying the bugs to actually wiping them out. For almost all common mammalian bites, you basically have one superpower drug: oral amoxicillin clavalulate, or if it's a severe case, IV ampicillin sulbactam. It is your absolute no questions asked first-line treatment for dog, cat, and human bites. It beautifully covers Pasteurella, Staph aureus, anaerobes, Eikenella, and Capnocytophaga. It is the ultimate board answer default for bite wound antibiotics. And you don't just sit around and wait for an infection to fester. You must instinctively prescribe prophylactic antibiotics, usually for 3 to 5 days, for specific high-risk scenarios. All human bites get prophylaxis. All monkey bites. Almost all cat bites, especially if they are anywhere near the hands. And dog bites? Only if there's a crush injury, joint involvement, or if the patient is asplenic, diabetic, or immunocompromised. Listen to me very carefully on this one, because it's an absolute rule. Because of the extreme infection risk from those deep, narrow punctures we talked about, you must leave cat bite puncture wounds open. Do not suture them primarily. And the exact same rule applies to human clenched fist injuries. Now, the only real exception to the primary closure rule is for facial wounds. That's due to the excellent blood supply and obviously cosmetic concerns, provided they are heavily irrigated first, of course. But otherwise, leave those high-risk punctures open to drain. Finally, Section 5, High-Yield Exam Traps. Welcome to the danger zone. Let's wrap up our boot camp by highlighting the exact pharmacological traps the board examiners are going to use to trick you. Picture this. A patient comes in with a rapidly progressive hand cellulitis after a cat bite. Normally, for typical skin cellulitis, you might instinctively reach for an anti-staphylococcal penicillin, right? Something like decloxacillin or nafcillin. But remember, Pasteurella multisida, it is uniquely and highly resistant to decloxacillin and nafcillin. If you pick that empiric treatment on your exam, the patient is going to fail treatment and you are going to fail the question. You must choose amoxicillin clavulanate. Similarly, picking clindamycin alone is a trap because it has really poor activity against Pasteurella. I want to leave you with this final provocative test. Let's say your patient works at a zoo, or maybe they just returned from overseas, and they've been bitten by an old-world macaque monkey. What fatal central nervous system infection must you prevent immediately, and how do you do it? The answer is B virus, also known as herpes virus simiae. It causes a serious, often completely fatal encephalitis in humans. You do not wait for symptoms here. You must immediately initiate emergency prophylaxis with an antiviral like valacyclovir. It perfectly highlights how one simple bite, if misunderstood, can literally be the difference between life and death. So keep these high-yield pearls locked in, and you'll be ready for anything the boards or the ER throw at you. Keep studying hard, and we'll see you in the next explainer.